classes, descending tracts. First point is general plan. Descending tracts of the spinal cord are the motor or efferent tracts. And these motor or efferent tracts, which is the descending tracts of the spinal cord, these tracts are running through the anterolateral white column of the spinal cord. And these descending tracts are the component of efferent or descending or motor pathway. So there is some relationship between the descending tract and descending pathway, or efferent tracts and efferent pathway. Efferent pathway, that is motor pathway, which is minimum component of efferent tracts are at least 2 order of neurons. And this 2 order of, it may be more than 2, it will be clarified subsequently during the class. So at least 2 order of neurons. One of this neuron, and which is located above the level of spinal cord. So this nucleus or this center is known as supraspinal centers. Broadly it is supraspinal centers. These centers are above the level of spinal cord, and where there is a new nerve cell body is forming the centers which is above the level of spinal cord. It may be in the cerebral cortex, or that means supraspinal centers in the cerebral cortex, or it may be anywhere between the spinal cord and the cerebral cortex, so which are known as, therefore, in relation to and reference to the cerebral cortex, can be termed as subcortical centers. That can be called as a subcortical centers. All of these are at the higher level, upper level, which are known as upper motor neuron. Next is, that is, it projects into the neurons, motor neurons of the spinal cord, and which is in that reference is known as the lower motor neuron. So upper motor neuron having a command on, what kind of command, it will be seen later on, it will be clarified later on. So command on the lower motor neuron for various kind of voluntary muscular, I can say not the movements, voluntary muscular activities, which includes the voluntary movements of skeletal muscles. So that is general plan. After this, next point is, that is groupings. Groupings of these descending tracts. Second point is groupings. These descending tracts, if you see this diagram, sketch, this is very technically important diagram which you will never find in a book, but it can be considered for is, that is comprehensive knowledge, comparative knowledge, that you see that here the groupings, tracts are basically divided into 2 groups. Basically divided into 2 groups. One, that is the red color, if you see that tract is projecting directly from the spinal, your cerebral cortex, directly to the motor neuron of the spinal cord. So from cortex to spinal cord. So that can be called as a corticospinal tract. In reference to the corticospinal tract, we come to 2 important points. Similar to the corticospinal tract projecting where lower motor neuron in the spinal cord. Similarly, if we see from cortex, there is a tract projecting from motor area of the cerebral cortex to relay in the motor nuclei of cranial nerves. So motor nuclei of the cranial nerves, which are equivalent to the lower motor neuron on the spinal cord, therefore can be considered as a lower motor neuron. So this tract is known as corticonuclear tract. So this is corticospinal tract, corticospinal tract, and this one is the corticonuclear tract. Corticonuclear tract. So it is also like the corticospinal tract projecting into the lower motor neuron, which is not in the spinal cord but above the spinal cord in the motor nuclei of cranial nerves. Apart from this, there are some other descending tracts we can see here. These tracts, I told in the beginning that descending pathway or efferent pathway is at minimum composed of 2 order of neurons, but it may be more than 2. That will be clarified from this side of the sketch or diagram. When we see that this is the tract projecting from, fiber tract projecting from cerebral cortex to the pontine nucleus. So cortex to pontine nucleus or nucleus pontis, from where it projects to the cerebellum, and from cerebellum it projects into various brainstem nucleus, which can be considered as supraspinal center in the brainstem. These nuclei are of various kinds in various level, starting from midbrain up to the medulla, which are number 1, that is substantia nigra, number 2, radicular nucleus for the whole length of the brainstem, number 3, vestibular nucleus at the pontomedullary junction, and next number 4 and 5 are these red nucleus and tectum in the level of the midbrain. Last one, that is olivary nucleus, which is in the medulla, of which if you see there's cortex to nucleus pontine, nucleus pontis corticopontine fiber, pontocerebellar fiber, then from cerebellum it projects where? It projects into 1 reticular nucleus, not substantia nigra, reticular nucleus 2nd, 3rd vestibular nucleus, and next is red nucleus, and after that is the olivary nucleus. So this cerebellum ultimately cortico-ponto-cerebello, then vestibular, cerebello-reticular, cerebello-vestibular, cerebello-rubral, cerebello-olivary. 1, 2, 3, 4. And from these 4 out of the 6 nuclei in the brain stem, they project into the spinal cord, ultimately as the respective tracts, which are not direct corticospinal tract, but as always these fiber tract has got the supreme command from the cerebral cortex, so that can be considered as indirect corticospinal tract, which are indirect corticospinal tract. Next you see, similar kind from the cerebral cortex, you see that upper motor neuron projects onto the thalamus and basal ganglia. As they project in the thalamus and basal ganglia, it is the basal ganglia from where descending fiber go directly to the subthalamic nucleus, taking part in the formation of the extrapyramidal nervous system circuit. So that is different story. But beside these descending fibers from this thalamus and basal ganglia, means stratum, they project again into this brainstem nuclei. What brainstem nuclei? They project into the number 1 substantia nigra, next reticular nucleus, next vestibular nucleus, and after that they replace the red nucleus, take turn after this, not the olivary nucleus. So they project into 1, 2, 3, 4, 5 out of the 6 chronologically. Substantia nigra, reticular nucleus, vestibular nucleus, red nucleus and tectum. And from these descending fibers which project into the spinal cord as the respective tracts. So these are also another component of the indirect corticospinal tract. But when we describe, when we just discuss what we study, what we see, that these two tracts, direct corticospinal tract and indirect corticospinal tract, are more easily and broadly classified into two groups. More easily and into two groups, what? Apart from this corticonuclear tract which gets exhausted in the level of the brain stem, it is the corticospinal tract which is the direct. We know that they pass through the medullary pyramid. So as this direct corticospinal tract projects through the medullary pyramid, and this tract is known as the pyramidal tract. So which can be called as also the pyramidal tract. Pyramidal tract. As this is the pyramidal tract passing through the medullary pyramid, all these other descending tracts projecting into the spinal cord, they are not passing beneath or deep to the bulge of the pyramid of the medulla, but they pass to the central core of the brain stem, so they are outside the pyramid. So non-corticospinal tract are also known as extrapyramidal tract. Next important point. After this groupings, next is principle of function. Principle of function. Principle of function. We know simply that descending tracts or efferent tracts are for voluntary movements, for contraction of skeletal muscles or muscles, single muscle or muscles, resulting into the voluntary movements. But these voluntary movements is not such a simple thing. These voluntary movements of the body, which is possible only because of many factors. Suppose a muscle made up of contractile tissue, so which is characterized by the power of the contractility. These muscles, all the muscles of the body in our living condition, they are present in the form of partially tonically contracted state, which is known as the tone of the muscles. So, functions, principle of functions is that not only it is voluntary movements, it is voluntary movements plus at least minimum tone of the muscles, which is also essential. Along with that, but when we execute one kind of movement, these kind of movement, particular kind of movements in the body, which requires what? That is coordination of the muscle movement. So contraction of skeletal muscles, number 2, maintenance of the muscle tone at least the minimum level, number 3, coordination of the muscle movements. Coordination of the muscle movements means when there is a contraction of the prime mover or agonist, there is necessity of what? The antagonist to be relaxed. So antagonist to be relaxed, there cannot be simultaneous contraction of this antagonist. That goes to the term that is coordination of the muscle very, very broadly. So coordination of the muscle movement towards the postural adjustment. So number 1 function is that descending tracts principle of function is that voluntary movements with the muscle, maintenance of the muscle tone, coordination of muscle movement, and along with that word that is for postural adjustment. Number 1. Number 2, that is the motor tract. Apart from the motor activities, this motor tract, descending tract has got some other functions. What some other functions? That apart from these voluntary activities, these tracts has got the function which is known as moderation or modulation. Modulation or moderation. Modulation or regulation in true sense of the term. Regulations. That is, it regulates something. So it is concerned with regulations, moderation or modulations of something. What? 1, 2, 3. What 1, 2, 3? Number 1. In connection with the sensory tract, we have discussed that sensory neurons in the spinal cord, where from the axons are passing to from the ascending tract carrying the various kind of sensory impulse, particularly the pain sensation, which sometimes needs to be moderated, which is moderated, regulated, restricted by the command from the higher centers. That command comes from these descending tracts, from the upper motor neuron. Suppose pain sensation from the periphery carried by the first order of neuron, second order of neuron in the spinal cord. After that, crossing the corpus upward to form the spinothalamic tract. This neuron, sensory neuron in spinal cord, receives some command from higher centers, that is cortex, by these descending tracts. So regulations of the sensory informations, perception, not informations, perception of the sensation, which is one important function of the descending tract. Number 2, we know that at local spinal cord level there is a reflex arc. In the reflex arc and in the local spinal cord level, in the reflex arc, what do you know? That reflex arc has got the receptor, afferent path, efferent path, effector. So there is a reflex action. This reflex action is also having the command from the heart center, that is by the efferent tracts or descending tracts. So regulations of the reflex pathway, reflex activity. Number 2. Number 3, there are some descending fiber pathway from the level of the hypothalamus, not from the level of the cortex, which are also passing through the spinal cord to project into the, that is autonomic centers in the spinal cord level. It means that thoracolumbar, first lumbar to L2 level, up to first thoracic to L2 level for sympathetic center, and S2, S3, S4 for parasympathetic center. These centers, that is, what are these cells? What are these neurons? These are general visceral efferent neurons in the spinal cord, sympathetic or parasympathetic, which receive some projections or command or restriction or regulation by the heart centers. So 1, 2, 3, apart from these voluntary activities with the muscle tone and the coordination of the muscle movement, that is modulation of sensory perception. Number 2, modulation of the reflex activity in a local segmental level. Number 3, modulation or regulation of visceral activity. So these are the principle of function. After this, if we see that individual tracts, first comes, that is your pyramidal tract or direct corticospinal tract. This direct corticospinal tract, which projects into the lower motor neuron, if we see therefore corticospinal tract, pyramid, olive, inferior cerebellar peduncle, and below this level is the spinal cord. Pyramidal tracts are so called because you see therefore the neurons corticospinal fibers passing to the deep to the pyramidal elevation, where 75 to 90% of the fibers decussate in the lower half of the medulla. They decussate in the lower half of the medulla. As the 75% decussate in the lower half of the medulla, so if these be the ligamentum denticulatum level, behind this ligamentum denticulatum, these fibers pass to the spinal cord. And this remaining smaller quantity of the fibers, they pass vertically through this, passing uncrossed, they pass to the anterior white column. One is in the lateral white column, one is the anterior white column. So lateral corticospinal tract, which is passing through the lateral white column behind the posterior to the level of ligamentum denticulatum, and which is already a cross fiber, therefore having the contralateral influence on the spinal motor neuron. But this anterior corticospinal tract, and which remain uncrossed to pass to the level of the spinal cord, when they reach to the level of the spinal cord, here is the fiber in respective spinal cord segment, they cross from the level of the anterior white column. Individual segment wise they cross and they pass to the opposite sided lower motor neuron. So ultimately it is also a cross fiber. But this anterior corticospinal tract, which is existent only up to the level of the thoracic segments of the spinal cord, not beyond that. So very small quantity, that is 10 to 25% of the fibers, which is existent up to the level of the thoracic level of the spinal cord. Next, if we go to, that is these fiber tracts reaching this level of the spinal cord, and which has got fundamental difference with the corticonuclear tract. So pyramidal tract, direct corticospinal tract has got a fundamental difference with the corticonuclear tract. What is the difference? Difference is that these are the fibers which is just having the influence on the contralateral side of the lower motor, contralateral sided lower motor neuron, the spinal cord. But corticonuclear tract, which are projecting to the motor nuclei of cranial nerves in different level of the brain stem, they have the bilateral control, with the exception of only one nucleus, that is the inferior part of the facial nerve nucleus. Apart from the inferior half of the facial nerve nucleus, if you think of all the motor nuclei of the cranial nerve, that is the 3rd, 5th, 7th, 9th, 10th, 11th, 12th, in all the cases excepting the inferior part of the facial nerve nucleus, they are having the bilateral control, means they are 4. In case of the corticonuclear tract lesion, there will be very little significance if it is above the level of the cranial nerve nucleus. Supranuclear lesion, only effect will be in the lower half of the face, which is be paralyzed in the contralateral side in case of the supranuclear lesion of the facial nerve, because inferior half of the facial nerve nucleus supplies the muscles of the lower half of the face, escaping the upper half of the face. So that is the basic difference of these two. In connection with this, if we see that extrapyramidal tract, if we see, the most important tracts are two, that is number one, reticulospinal tract, and vestibulospinal tract. Reticulospinal tract and vestibulospinal tract. These are most important extrapyramidal tract. So for this extrapyramidal tract, we have to see that apart from this, other tract will be coming subsequently. Therefore, if we see, suppose this is in one side, so this is the position of ligamentum denticulatum. Behind this, there is the central part, posterior part of the central area of the lateral white column. This is the position of lateral corticospinal tract. This is the position of lateral corticospinal tract. And from previous diagram, if we see that this is the position of ventral or anterior corticospinal tract. These are the two positions. In addition to that, reticulospinal tract. Reticulospinal tract starts from medullary and pontine reticular nucleus. So there are two reticulospinal tract, lateral and medial reticulospinal tract. Lateral reticulospinal tract is situated just lateral to the anterior horn. Lateral to the anterior horn, obviously it is in the anterior white, it is lateral in the lateral white column. It is in the lateral white column. And this medial reticulospinal tract lies medial to the anterior grey column. So this is medial reticulospinal tract is here, and this is lateral reticulospinal tract. Lateral reticulospinal tract, this is medial reticulospinal tract. These two. Lateral reticulospinal tract starts from medullary part of the reticular nucleus in the brainstem. Medial reticulospinal tract starts from pontine part of the brainstem reticular nucleus. And these two tracts of this, which extends all through the level of the spinal cord. And this lateral reticulospinal tract is the cross tract, and medial reticulospinal tract is an uncrossed tract. Both these tracts has got the independent functions. Lateral reticulospinal tracts are concerned with, that is, control or the regulation of the voluntary movements, regulations or modulations of the motor activity. And also earlier we have discussed the modulation of the sensory perception. That is the function of the lateral reticulospinal tract. Medial reticulospinal tract, and which is having the different functions. that is concerned with, that is steering of the head and the trunk in response to the postural adjustment of the body. Steering of the head and the trunk, that means movement of the trunk, is reference to the postural adjustment of the body. Vestibulospinal tract are also two. They are lateral and medial vestibulospinal tract. They come from vestibular nucleus. Lateral vestibulospinal tract, which is a cross tract, and medial vestibulospinal tract is both crossed and uncrossed tract, and both these tracts are coming from the vestibular nuclei at the pontomedullary junction, and lateral vestibulospinal tract originates from lateral vestibular nucleus, easy to remember, and medial vestibulospinal tract which takes origin from inferior and medial vestibular nucleus mainly, and partly also from the lateral vestibular nucleus. Whatever it is, these vestibulospinal, both the lateral and medial, they are situated just covering the anterior as well as the part of lateral white column, anterior as well as the lateral white column together. This is vestibulospinal tract. This one is vestibulospinal tract. This is vestibulospinal tract. Function of the vestibulospinal tract is very important. That is what? That as it is coming from the vestibular nucleus which receives afferent inputs in reference to the change of the equilibrium or the balance of the body, as per the requirement of the balance of the, in reference to balance of the body or equilibrium, position of the body is adjusted by the motor activities, and this is the function of the lateral and medial vestibulospinal tract. Where it is a lateral vestibulospinal tract and which is concerned with the adjustment of the movements of the trunk and the proximal part of the limb, upper limb, trunk and proximal part of the upper limb, and medial vestibulospinal tract which is concerned with the adjustment of the head and neck. So these are in reference to the alteration of the body balance, vestibulospinal tract. Apart from these, other tracts are, that is, one is rubrospinal tract. This rubrospinal tract which lies here, we know that in front of lateral corticospinal tract, this is rubrospinal tract. 2-3 important points just to tell in connection with this rubrospinal tract. Rubrospinal tract is a cross tract arising from red nucleus of the brainstem. Rubrospinal tract, after decussation passing to the central core of the brainstem, it descends in the lateral white column just in front of this. But rubrospinal tract is extend only up to the level of the third cervical segments of spinal cord. So which is up to C3 level of spinal cord, rubrospinal tract. So function therefore can easily be understood, that which is adjacent to the corticospinal tract, lateral corticospinal tract, which is function of which is similar to the corticospinal tract. So rubrospinal tract. Tectospinal tract is here in the anterior funiculus. Just briefly you have to cover these points. We cannot leave this uncovered. This is tectospinal tract. This comes from the tectum. So this is tectospinal tract. Tectospinal tract is also cross tract from the midbrain, from the tectum of the midbrain, and which takes part in the formation of the efferent component of the spino-visual pathway reflex. Therefore, spino-auditory and spino-visual pathway reflex. Therefore, adjustment of the body in reference to the light falling on the retina or the sound coming in the ear received by the ear, and this is the function of tectospinal tract, and which extends up to the cervical segments of the spinal cord. Only up to the level of the cervical segment of the spinal cord. So this is, last one is olivospinal tract. Only one important point to tell that It is coming from inferior olivary nucleus and it is located here. In the lateral white column, I show in a dotted line because this is olivospinal tract. Olivospinal tract is like this because you see that olivospinal tract, which is poorly existent in human brain, so human nervous system. So function is also of the olivospinal tract is doubtful. So this is the location, extent, location and basic function of the extrapyramidal tracts. Next is very important point to discuss, that is terminations of pyramidal and extrapyramidal tract. This is an important area to discuss, termination. In one sentence we can tell that these both the tracts just project or terminate in the anterior horn cells. This anterior horn cells lie in the anterior grey column, which are of two different types. One is alpha neuron and another is gamma neuron. Alpha and gamma neurons. So, pyramidal tract project on the alpha neuron directly as also indirectly through the interneurons. Whereas extrapyramidal tract, what I tell, pyramidal tract project directly onto the alpha neuron or indirectly to the alpha neuron through the interneurons. So you see therefore this is the interneuron, this is interneuron, and pyramidal tract is mainly concerned with what? That skilled fine movements of the body, fine voluntary movements which are mainly concerned with the peripheral part of the limbs. The flexion antagonized by the extensor, abduction antagonized by adductors, like that. So rotation, medial rotation antagonized by lateration or vice versa. Therefore, it is concerned with the skilled finer movements in the distal part of the limbs mainly. Whereas extrapyramidal tracts are concerned with the gross movement patterns. Therefore, widespread movement of the body, that is the function of the extrapyramidal tract. Basic reference in the termination is that pyramidal tract, as it terminates, if you see therefore, this is this pyramidal tract project here. If we see this different color, it will be easier to understand. It projects here, it projects here. This pyramidal tract projects here. Pyramidal tract projects into the alpha neuron. Here both these are alpha neuron, these are alpha neuron. In this diagram both these red neurons are alpha neurons and this is interneurons. Therefore pyramidal tract project into alpha neurons. One is directly, in the diagram it is clear, another is indirectly through the interneurons. What for it is? It is that when pyramidal tract influences on the activity of the lower motor neuron, there are varieties of the lower motor alpha neurons. Suppose in this joint, if we see here the knee joint, where we see that alpha neuron, when it supplies, just innervates extensor muscle of the knee. And this alpha neuron also supplies what? Flexor muscles of the knee in the back. So when this is stimulated by this pyramidal tract, this alpha neuron, it gives rise to the contraction of the quadriceps or extensor of the knee. Therefore at that time, and this contraction of the antagonist must be restrained from. It is restrained from by the activity of the interneurons. So pyramidal tract projecting on the interneurons which project having the inhibitory effect on those alpha neurons which goes to supply this antagonist. So that is the role of the interneurons in connection with the termination of the pyramidal tract. So pyramidal tract, when it is like this, extrapyramidal tract, and which does what? Extrapyramidal tract project on both alpha as well as gamma neuron. So if this is the smaller one, this is gamma neuron, this is smaller gamma neuron, this is alpha neuron, this is alpha neuron. Extrapyramidal tract project on both these alpha and gamma neuron. So if you see that, it relays here, it also relays in the alpha neuron. Important point is that for coordination of the muscle movement, for maintenance of the muscle tone, and therefore what, that is role of gamma neuron is very important. Gamma neuron, as you see this diagram, gamma neuron is constantly being stimulated in the body. As gamma neuron is being constantly stimulated in the body, lateral one, smaller one, these stimulation give rise to what? These give rise to what? This impulse is traveling, action potential is passing through this, and this gamma neuron axon, which just end into, this is the muscle spindle, one lies these intrafusal fibers. These are intrafusal fibers of muscle spindle. Intrafusal fibers of muscle spindle. So constant impinge or stimulation of the gamma neuron on the intrafusal fibers, what there are two different kinds, we nuclear back fiber and nuclear chain fiber, but we have shown only one here, that is nuclear back fiber, which have got three components. Central part or middle part, that is in the middle, which is dilated because the nuclei are just accumulated there. And this is the central part is the sensory part peria, that is receptor part of the muscle spindle. That is intrafusal fibers in the muscle spindle. And two ends are, these are the skeletal muscle, but interfusal, and these are skeletal muscle within the muscle spindle. So they are having the contractile element which are lying in the distal parts, both ends. So this gamma neuron, when it is passing, it is just impinging upon these ends of the muscle spindle. That is the nuclear back fiber or nuclear chain fiber, which are contractile in nature. So as soon as it is stretched both ends, as both ends are stretched because of the contractility, that is, this central part gets stimulated. And the central part gets stimulated, this afferent impulse carried from the central part, which is passing through the afferent nerve fiber of the spinal nerve, entering this and reaching the spinal cord, and this will do what? This will stimulate the alpha neuron. As it stimulates the alpha neuron, it will just go to innervate, that is extrafusal fibers of the skeletal muscles. So this is extrafusal fiber, this is extrafusal fiber, and which show this contraction. So this is the constant thing happening in the body. And all around the clock this is going on this circuit. So this is the normal activity which is having in this gamma neuron, and which is being restricted by these extrapyramidal tract fibers. So this extrapyramidal fibers, this is extrapyramidal tract, this is extrapyramidal tract, and which has got a regulatory action on the gamma motor neuron. As it is having the regulatory action on the gamma motor neuron, that is why in case of what? In case of the extrapyramidal tract lesion, that is why that is inhibiting effect on the gamma motor neuron, inhibiting whip on the gamma motor neuron is relieved because of the lesion which is cut up. Therefore, it will be more hypertonic. So muscle tone will be, that is why, increased. This is the explanation why the muscle tone is increased. Same is for what? Once the muscle tone is making increase, more stimulation in the local segmental reflexor, this will give rise to the exaggeration of the tendon juts, which is a proof or elicitation for the function or integrity of the local spinal cord segmental reflex arc. So, this is having the extrapyramidal tract on the gamma motor neuron is having inhibitory influence. So, having influence both on this alpha and the gamma motor neuron, having this restriction or this modulation of this action here. So, that is why in extrapyramidal lesion, it happens like this. If we understand this, then it will be easier to discuss about the upper motor neuron lesion of the spinal cord. So, clinical anatomy related to the descending tracts. Clinical anatomy related to the descending tracts, of where there is a term which is known as, basic term is the upper motor neuron lesion. Clinical anatomy related to the descending tract. There is a term which is known as upper motor neuron lesion. Upper motor neuron lesion. This upper motor neuron lesion is mostly vascular in origin. Upper motor neuron lesion in the central nervous system is mostly vascular in origin, and which mostly occurs in the subcortical center, subcortical area, means beneath the level of the cortex of the cerebrum. This means at the level of the white matter, central core of the white matter, where lies the internal capsule. So mostly it is vascular in origin. That is why upper motor neuron lesion is quite something different from pyramidal tract lesion independent. Pyramidal tract lesion is very, very rare. It is possible, it may occur where? Only if there is a damage in the pyramidal area of the medulla. So further lower down, in the level of the pyramid, and pyramid of the medulla is supplied by multiple medullary branches which are clinically known as paramedian arteries. These paramedian arteries are multiple. So there is very rare chance of lesion, vascular lesion in the pyramidal tract only. Therefore, upper motor neuron lesion means it is a combination of what? That is pyramidal as well as extrapyramidal tract lesion, because high up above the level of the medulla, beneath the level of the cortex, in the medullary substance of the cerebrum, they are very closely opposed to each other together. So upper motor neuron lesion is a combination of pyramidal tract lesion and extrapyramidal tract lesion. So it gives rise to various features. Number one is that paralysis. And this upper motor neuron lesions paralysis, which is due to corticospinal tract or pyramidal tract, there is loss of what? Loss of voluntary movements of muscles. Loss of voluntary movements, but for pyramidal tract lesion, it is the lesion which causes what? Loss of fine, skilled movement, which mainly affects the extremities. So it is only affecting these extremities. And as there is a paralysis, this is associated with what? The abolition of the local reflex arc. So segmental reflex arc, and this is elicited clinically by what is known as plantar reflex. This plantar reflex, normally what happens, plantar reflex says, that is integrity of the reflex, segmental reflex pathway, in which case when there is the scratching of the lateral board of the sole of the foot, impulse travels to the afferent components of the plantar nerves, ultimately the tibial nerve, then starting nerve, finally the spinal cord. So reaching the spinal cord would happen. That is because of the pyramidal tract. In normal cases what happens? Local reflex arc, because of this efferent pathway, it gives rise to the flexion of the sole of the foot, with the flexion of the toes. So that is normal plantar reflex elicited in normal individual. But in case of pyramidal tract lesion, what will happen? This local reflex arc is commanded by what? That is the pyramidal tract from above. So as the pyramidal tract is cut off, therefore it will give rise to, that is, abolition of the plantar reflex. If it is only the lesion of the pyramidal tract, it is abolition of the pyramidal tract which will be characterized by some other phenomena, some other movements of the foot, what is known as withdrawal phenomena. That is known as withdrawal phenomena. If it is lesion only in the pyramidal tract, withdrawal phenomena. What is that? Withdrawal phenomena, if that is extrapyramidal tract is intact, only pyramidal tract lesion, these will give rise to, instead of abolition of the plantar reflex, no plantar reflex, instead of that, that is because of the afferent sensation is carried through this nerve, spinal cord, sensation perceived, as sensation perceived by the ascending tracts, therefore as per the perception of the sensation, what will happen? That is extrapyramidal pathway will come into action, which will give rise to the withdrawal effect of the limbs. So there will be a flexion of the, if we hold this leg by the clinician, then what will happen? That is a tendency to flex the limb. Along with that, what will happen? Just opposite sided muscles, so long tendons are there on the dorsal aspect, extensor aspect. It will give rise to a dorsiflexion of the great toe with the abduction or what is called the fanning of other toes, which is known as Babinski sign positive. That is known as Babinski sign positive. So this is Babinski sign positive because of this withdrawal phenomena. In case of infants up to the age of first year of life, before the second year of life is achieved, corticospinal tract is still non-myelinated. So because of non-myelination, dissociation of the velocity of conduction of the action potential will give no result, same as the paralysis or lesion of the corticospinal tract. So long it is not myelinated, dissociation of dispersion of the velocity of conduction of action potential, this will give rise to no result, which is also similarly in case of infants after the first year of life, before second year of life when myelination starts, there will be a similar kind of this Babinski sign positive. Effect of extrapyramidal tract lesion, what will happen? Effect of extrapyramidal tract of lesion will give rise to what? That is loss of, that is widespread paralysis. It will cause widespread paralysis. All groups of the muscles will be paralyzed and therefore leading to this incoordination. In addition to that, more important is that if you just realize this diagram, therefore you see that this is the extrapyramidal tract projecting on the gamma motor neuron. So gamma motor neuron is receiving inhibitory effect by the extrapyramidal tract. In lesion of extrapyramidal cut, this inhibitory effect is cut off. Therefore, the tone of the muscle will be increased. State of partial contraction of the muscle will be more increased. This lower motor neuron, the gamma motor neuron, will go as per its own way. Therefore, it will give rise to increase on the muscle tone. The muscle will be more in the tonically contracted state. As more tonically contracted state, therefore, it will be related to what? And if you elicit the tendon jerks, and which proves the integrity of the local segmental reflex arc, therefore, if you elicit tendon jerks, what will happen? It will give rise to exaggeration of the tendon jerks. So, tendon jerks is exaggerated, muscle tone is increased, but muscle is paralyzed. So, increased muscle tone in the paralyzed muscle will give rise to finally what is called the spastic paralysis. That is giving rise to the spastic paralysis. In contrast to the upper motor neuron lesion, lower motor neuron lesion is very simple, because lower motor neuron lesion means spinal cord level. Spinal cord level if there is a lesion, spinal cord level if there is a lesion here, anterior horn cell. Therefore, as a whole anterior horn cell means everything is cut off. You know that from anterior horn cells, mental nerve roots of all kinds of motor neurons, alpha, gamma, all kinds of motor neurons receiving influence, excitatory or inhibitory influence by the pyramidal and extrapyramidal tract. All what is this? It is of no result, because death is here, the lesion is here. Means therefore, there is no impulse carried to the effector organ. Paralysis with the loss of use, loss of muscle tone, loss of reflex, everything is clear from this circuit, and this will give rise to what is known as the flaccid paralysis. In contrast to that is known as flaccid paralysis. Flaccid paralysis in lower motor neuron. You know that happens in case of lower motor neuron, but there are some clinical condition where there is selective damage of the descending tracts at the spinal cord level. Upper motor neuron lesion we have told above in the supraspinal level, but in the spinal cord level there also occurs some upper motor neuron type of lesion. Means what? That is lesion in the descending tract passing to the white column. And there are two different kind of diseases which are known as number one, amyotrophic lateral sclerosis. Sclerosis means degeneration. Sclerosis or degeneration in the lateral white column, involving the damage to the lateral corticospinal tract. And this amyotrophic lateral sclerosis, which usually occurs in the older age and adulthood, in adult life, and which is an irreversible disease, this will give rise to the selective lesion of the lateral corticospinal tract. Degenerative disease leading to causing selective lesion in the lateral corticospinal tract. So this will give rise to the spastic type of upper motor neuron of paralysis. In contrast to that, there is another disease occurring in young adults. That is younger age group. It is occurring, that is known as multiple sclerosis, which is known as multiple sclerosis. This multiple sclerosis occurs in younger age, and this is having some predisposing factors and precipitating factors. Predisposing factors are autoimmunity and heredity, and precipitating factor is infection. So infection results into what? Lesion in the lateral white column, which is known as that is multiple sclerosis, where there is a lesion in the lateral white column, affecting lateral corticospinal tract along with the tract in front, that is sensory tracts. So there will be the loss of sensation and also loss of voluntary activity, which is upper motor neuron type of lesion, because lesion is in the tract level and this is below the level of the lesion, and which is a spastic paralysis associated with it extends where it extends at that particular segmental level. It also damages what? It damages, that is anterior horn cell. So it will give rise to the lower motor neuron lesions, loss of function of the muscles in the lower motor neuron type in this particular segment affected. So in this multiple sclerosis, two important points I will tell. Number one, occurring in younger age group, it is a reversible disease characterized by what? Characterized by, that is, regeneration and recurrence, which is a demyelinating disease. It is because of loss of myelin sheath of the descending tract fibers, that is corticospinal tract fibers. So demyelination leads to what? Which is because of infection in the neural tissue, because of loss of blood activity of the blood-brain barrier, leukocytes which are percolated, crossing through the blood-brain barrier, leading to the infection, results in demyelination. Demyelination gives rise to the loss of function, spastic paralysis. Later on, it is what? That is regeneration and recurrence. So this is again, that is exoplasm, the cytoplasm of the axons of the descending tract, and which shows a remodeling, and this remodeling again gives rise to the artificial myelination. So sometimes it is followed by, that is regeneration and remodeling into regeneration. So again regaining function, after regaining then finally it is resulting in the degeneration finally. So that is a multiple sclerosis, quite different, where there is a lesion also affecting the sensory tracts. So loss of sensation below the level of lesion and also lower motor neuron lesion, and which is at the level of the spinal cord which is affected. That's all.